Welcome to UMDF's Ask the Mito Doc monthly webcast. Tonight, two excellent clinicians who have extensive experience with CPEO will be presenting this evening. We have Dr. Rustam Karangia from the University of Ottawa Eye Institute and Dr. Zoela Zulkifli-Cunningham from Children's Hospital of Philadelphia. Also joining the panel for Q&A are Daniel McGinn and Jean Flickinger, both from CHOP. Our Ask the Mito Doc webcasts are made possible through the generosity of sponsors, so we ask that you join us in thanking UCB. We are already busy making plans for our next UMDF annual conference for patients, families, researchers, clinicians, and industry. Meet us in St. Louis for Mitochondrial Medicine 2025, June 18th through the 21st. Save the dates now and more details to come at umdfconference.org. Please note, the information provided in this webcast is for general information only and should not be relied upon as a substitute for professional consultation with a qualified healthcare provider familiar with your individual medical needs. Please consult your primary physician and/or specialist before changing the course of your care.
Welcome, everyone, to our January version of Ask the Mito Doc, a comprehensive vision, understanding chronic progressive external ophthalmoplegia, I did practice, CPEO, from the eyes to the body. We'll have several speakers today, actually 3, but we're going to get started with Dr. Rustam Karangia. He will be, his camera's not working great, so you may not be able to see him today, but he's going to be popping on in a second. So take it away, Dr. Karangia.
Thank you for including me in the session, and I look forward to having some questions and discussion at the end of my presentation, but hopefully I am able to make things a little bit clearer for you with regards to how an ophthalmologist approaches CPEO and the things that we consider when we see patients who have CPEO. So to start with, primary mitochondrial disease, as most of the people know in this call, is any symptom, any organ, any age, and any mode of inheritance. So it can affect a multitude of different things. And when it comes to the eyes, it's interesting that the eye becomes a focal point for a lot of these diseases based on the fact that the eye has very high energy demands. And so you can imagine that any disease that ends up affecting energy production or energy distribution within the body is going to end up affecting the eyes in some way. So CPEO, in a way, is a final common pathway. It's a final end stage development that happens when you start affecting the eyes. And ophthalmologists have a tendency to use a set of languages that don't make sense to a lot of people. And so I just wanted to start off by trying to decipher some of those topics and some of those words that we use. And so what do we mean by external ophthalmoplegia? Well, I don't know exactly when, but at some point, somebody decided that the eye itself, the globe, anything that happened inside it was internal, and anything that happened outside it was external. So when we say external ophthalmoplegia, what we mean is that the eye is not moving on outside of the globe. If we talk about internal ophthalmoplegia, we're talking about eye not moving inside the globe, which essentially applies to the pupil. Ptosis is essentially that the eyelid is drooping, and that is typically a result of an ineffective nature of the levator palpebrae superioris, which is the muscle that lifts the eyelid. And then you get into a situation where you have diplopia. Now, diplopia is by definition seeing double, but there are 2 different types of diplopia. The one that concerns us more commonly as neuro-ophthalmologists is binocular diplopia. And that only happens when you have both eyes open, in the sense that if you cover one eye, doesn't matter which eye you cover, the diplopia goes away. This is in contrast to monocular diplopia, which happens predominantly for an issue with the light pathway getting into the eye and has more to do with the tear film and the cornea than it does with neurological disease. And then ductions, which is the movement of one eye, versus vergence, which is the movement of both eyes in sync. As you can imagine, when we move our eyes, we don't typically just move one eye off to the right or to the left. Both of our eyes track together. And it's an coordination between these 2 eyes, which results in strabismus or squint, which is basically where the eyes do not line up. And then when the eyes do line up, we call it orthopic. In sense, both eyes are centered and both eyes line up. And so some of you are probably thinking this at the end of all of that, but this is certainly something that my residents bring up, and we'll talk a little bit about later. So there are 6 muscles that move the eyes. 4 of the muscles do what we think they would normally do. They're located at the poles. They lift the eye up, drop it down, move it left and right. But then we have 2 other muscles that insert in a slightly different way and are responsible for the rotational effects on the eye. So as we tilt our head one way or the other, we also rotate the eye in order to compensate to a certain extent. And so an imbalance between the 2 eyes in any one of these functions results in binocular diplopia. Now, CPEO phenotypes can vary considerably, and the classical CPEO was first described in 1868. Now, in 1868, we did not know about genetics. We did not know about genes. And so CPEO was described as a phenotype, not a genetic disease or a particular gene causing disease. And for the most part, this was the original descriptions of it. There are other types of CPEO that have more predominant neurological features that Dr. Cunningham is going to talk about in a few minutes. And those would essentially categorize more as the CPEO plus variants. I'm going to concentrate more on the classical side of it in the CPEO variant, simply because from the ophthalmic perspective, we have a tendency to only pay attention to the eyes and go a little bit above and a little bit below. Everything else, I'm going to leave to Dr. Cunningham. So classically, CPEO was described as symmetrical bilateral ptosis, so droopy eyelids, bilateral progressive ophthalmoparesis, meaning that you have external ophthalmoplegia or an inability to move the eyes, orbicularis weakness, which is basically the muscles around the eye are unable to help close the eye very well. And so when you see a patient who has this, the first striking feature, the most common feature that people will notice is that the eyelids are drooping. And the eyelids can droop to the extent that they end up covering the pupillary axis, so they cover part of where the light pathway is going to be, and patients aren't able to see very well as a result. In addition to that, you have the external ophthalmoparesis. So we're asking this patient to look up, look down, look left and right, and you can see the eyes aren't moving as far as we would normally expect them to. Typically, you would expect the white part of the eye to get buried as you moved left and right. And as you moved up and down, you would expect to see more excursion or more movement than what we're seeing here. The interesting thing part with CPEO, though, is that only 8 out of 45 patients, or less than 20% of them, ended up noticing that they actually had an issue with their eye movement when you look at mitochondrial myopathy patients. In addition to that, when you talk about double vision and diplopia, well, 37% of patients were asymmetric motility. So both eyes did not move together. Only about half of them actually noticed that they had double vision, which means almost half didn't notice that. And the range of individuals who complained about diplopia was anywhere between about a quarter up to about 2/3. So part of this is the result of our brain and our body's ability to adapt to things. And you get into situations where you have something called flaccular suppression, where the brain starts to ignore the image coming in from one eye. And as a result, it no longer notices double vision, because if you're not noticing what's coming in from one eye and you're only paying attention to a single eye, you actually don't have a problem. The other side of it is that with CPEO, both of the eyes don't move. So if your natural resting position is fairly well centered, both of the eyes are going to be pointing at the right target. And patients learn to adapt by moving their head, and as a result, do not complain about double vision. So the other aspect of the double vision in CPEO is because of the ways the eyes are set up and the amount of tension that takes place to hold the eyes into position, the double vision is usually horizontal, more commonly than vertical. The differential diagnosis for this for an ophthalmologist is quite extensive and includes various different diseases, some of them genetic, some of them are in post-infectious, and then you also have some autoimmune conditions such as thyroid eye disease. All of these result in an inability to move the eyes. So the differential can be quite broad. And if you go in and see an ophthalmologist and they notice that your eyes aren't moving, they're not going to jump to CPEO right off the bat. They're going to have to go through and make sure that these other conditions are not present as well. Some of these have different treatment modalities that can be done. So it's important to make sure that they are ruled out. And again, if you ask my residents, this would always show up on the list. So you've got CPEO, and in some cases, you can also have concomitant vision loss. And this together is described as something called Kearns-Sayre syndrome. Now, Kearns-Sayre is associated with something called a pigmentary retinopathy. And it's important to rule out because it's more commonly associated with cardiac conduction deficits than those individuals who have CPEO and do not have the pigmentary retinopathy. And what do I mean by pigmentary retinopathy? Well, when you look at the back of the eye, as you can see in the top picture here, the retina usually has this kind of red glow to it that's pretty diffuse and extends all around the periphery of the retina. You have that little white circle over here, which is the optic nerve, and that's where the cable that takes all of the information from the eye goes to the brain. But if you have a look in this lower image, you're starting to see these black spots all the way around. And these are what we call bone spicules. And that is the first clue that you're starting to see a pigmentary retinopathy. Most commonly, it's associated with something called retinitis pigmentosa, which is a genetic disease. But in CPEO, the pigment changes are slightly different. They occur closer to the optic nerve and less in the periphery than what you see in a typical patient with retinitis pigmentosa. So it is an interesting thing to look for and to consider, but one of the important things to recognize is that you can have subtle changes that we're not going to see these pigmentary changes. So it's important to look for changes in the electrical activity inside the eye. And we typically do this using something called an electroretinogram. The other thing to consider is that even though patients who have CPEO do not have pigmentary changes or do not have electrophysiological changes in the eye, they can still complain of changes in night vision, problems reading small print. And interestingly, when you test these patients and look at them using a visual quality of life questionnaire, the visual quality of life is worse than some more common diseases that we commonly hear about, such as glaucoma and age-related macular degeneration. So it's not without its visual symptoms. Making the diagnosis, as I mentioned, can be a little bit challenging because you can have a presentation like this where you have limitations, inductions, and movements that mimic a lot of the other diseases that I showed you earlier. We can do imaging using an MRI, and you can see changes in the signal in the muscles that can be indicative of it. But more commonly, we end up having to go to a muscle biopsy and start looking for classical features associated with CPEO, predominantly this idea of ragged red fibers, which can be used as a pathognomonic diagnosis for this disease. In addition to that, the blood tests as well as the electrodiagnostics that I mentioned, and there are genetic testing that can be done. There are multiple syndromes that can be associated with CPEO, but I'm going to skip over these and leave them for Dr. Cunningham. And in addition to that, there are other things that can be associated with CPEO, such as cardiac conduction deficits, which I'm sure she's going to touch on. When it comes to treatment and when we're dealing with the eyes, as I mentioned, the most common thing that when you see a patient with CPEO, you notice is that droopy eyelid. And we can do multiple different types of surgeries to try and correct for that. But because you also have weakness in the ability to close the eyes, we have to be mindful of the fact that we don't want to lift the lid too high. If we lift the lid too high and the eye does not close and get covered and protected appropriately, there's increased risk that you can end up scratching the front surface of the eye, and that can lead to damage to the cornea, infection, and eventually potentially loss of the whole eye itself. So it's something that we have to be very careful about. It has to be done by people who are quite experienced and know what they're doing. This is not a cosmetic procedure to try and lift the lids. It is a functional procedure to try and lift the lids to provide the patient with the ability to see from that eye. And this can be done by sometimes lifting the lid and attaching it to sutures that go to the forehead, or in some cases by removing some of that levator tissue that I mentioned earlier, that muscle that is responsible for lifting the eyelids and making it tighter. The other thing that can be considered is when you have double vision. Now, most of the patients who have CPEO, the eyes line up quite well, but some of them, the eyes do not line up. And we can correct this by either doing a surgical procedure where we move the muscles so that we realign the position of the eyes, or we end up using prisms. Now, prisms essentially bend light, and they allow us to reposition the image in such a way that you can get things to line up. And you can use it for a variety of different circumstances and a variety of different reasons. It's also used in cases where we have an acute nerve palsy of one of the muscles controlling the movement of the eye, as was the case with Hillary Clinton. And you can see these little lines that are present in her glasses that were used to try and correct her double vision at the time. So CPEO has multiple spectrums. It goes from the basics that we just talked about now, and we're going to hear a little bit more about the more CPEO plus current Sayers and the other diseases associated with it. And it's important to recognize that we need a multidisciplinary team to deal with this condition. Ophthalmology in isolation doesn't really help you entirely. The last thing I wanted to bring up is this, and hopefully I didn't scare any of you, but OMG in our world doesn't necessarily mean what you think. It actually means ocular myasthenia gravis. And this is a condition in a way that can mimic CPEO. And so patients present with ptosis, droopy eyelids, ophthalmoplegia, and it's a disease of the communication between the nerves and the muscles. And it has a medical treatment for it. So like I said, just because the presentation seems to be like CPEO, we have to make sure that these other conditions are not present because the treatment for them is quite different. And so we have to take that into account when we see patients who present with similar symptoms. Thank you.
Well, thank you, Dr. Karangia. That was a very interesting talk. I'm always happy when we have these kind of resources available to our patient families to learn about what's going on with their condition. So next, I'd like to welcome Zoella Zokipley-Cunningham, Dr. Zoella Zokipley-Cunningham from CHOP, and she's going to tell us a little bit more about CPEO.
Okay, wonderful. Thank you very much, and very good to be here. I will be speaking on the other aspects of CPEO, meaning the other organ involvement, which is incredibly important to speak of. My name is Zoella Zokipley-Cunningham, and I am at Children's Hospital of Philadelphia. I have no disclosures to report relevant to this particular talk today. Okay, as you heard the elegant talk by Dr. Karangia on CPEO and the eye manifestations, right now I will focus on what else to look for, what else is important for your physicians to look for when they are assessing you in clinic. Indeed, we have seen many patients come to our clinic at CHOP where they have been seen by ophthalmologists and eye physicians sometimes for many years without having other organ systems assessed. It's really important that they are assessed because, in fact, what we've been showing, so both Dr. Karangia and my slides are showing you in these three boxes here, is that a reminder that it is indeed a spectrum. So this is a single mitochondrial DNA deletion disorder, first of all. So this is a genetic disorder that is sporadic, this particular type. So it is a mitochondrial DNA disorder that can present in many forms. If you see the box on the left that is above the word infancy, what we're trying to explain is that the spectrum of symptoms can change depending on the onset or the age of onset. So Pearson syndrome has onset in infancy, Sayers syndrome generally under age of 20, or at least when it was first described. And then there's CPEO that can happen in any age. And we primarily see it in adults, but also in older children. So this is a spectrum. It's not segregated completely by straight lines. Really important to say that sometimes it is hard to see where a patient is placed. And this phenotype, that's what we call it. The symptoms that you present with are a description of you, but ultimately it's the genetic diagnosis that makes a diagnosis. Hence, it's really important to be seen and followed in a mitochondrial clinic. So the other point to make is that it's a spectrum of severity, ranging from very severe, from Pearson's, very severe, Sayers syndrome, to potentially less severe, only because if it really is truly limited to the eye, then at least the other life-threatening symptoms are not there, so it's considered milder. But I will say I'm very careful with calling it mild, when in fact living with ptosis and restriction in your eye movements to the individual who has them indeed is not mild. It's limiting on your life. So a reminder, though, that it is indeed a spectrum, and it is important to have all organ systems assessed. You might, in fact, point out that CPEO and Kearns-Sayre, therefore, are very similar, and indeed it is. As I show you this next slide, Kearns-Sayre syndrome is very much a multisystem disorder. CPEO plus 2 is, in fact, a multisystem disorder. So you see it's very close between the two what one might have, which brings you still back to the fact that the genetic defect is, in fact, the confirmatory test. All of your organ systems in your body are essentially vulnerable to being involved, because mitochondrial DNA deletion can be in any tissue in your organ systems. And so it is very important that your heart is assessed even if you don't have any symptoms, because the heart involvement can be silent. It is important to have an EKG and echocardiogram, and not just one time, but progressively serially performed over time. So for example, if it was performed in 2005 and considered to be normal, it is important that it is repeated and reassessed every 1 to 2 yearly is what we would state, or at least do it when it's remembered, because it's really important to recall, really important to realize that if you do not have it at a particular point in time, it might evolve over time. And this is a really important point that we reinforce when we see our patients in clinic, because it's very common for us to hear, particularly from adults, "Oh, I've had it done in the past and it was normal." The GI system is very frequently involved in our patients. In a survey that I published in a paper in PLOS ONE to report the symptoms in 290 mitochondrial disease patients, GI symptoms was among the top 5 symptoms reported by patients. So muscle symptoms and GI symptoms are extremely common. And it's really not surprising, because it's the smooth muscles of the bowel wall that are affected in the similar way that the skeletal muscles of the limbs are. So you can get constipation, reflux, vomiting, nausea, abdominal distension on eating, abdominal discomfort on eating, and so forth. These are symptoms that are extremely burdensome to live with. They may lead to weight loss. They may lead to anorexia. So it's very important to have a GI physician on board. Brain tissue clearly is very demanding. It needs energy, and it is frequently involved. This may be silent, so involvement of your brain may not be evident, except if an imaging is performed and some changes suggestive of mitochondrial disease are evident. Or it may be evident. It may be evident by way of migraines, stroke-like events, or more severely, seizures. It may be evident in the younger patients with developmental delay or developmental regression. It may present in older patients with memory loss or difficulty remembering things or difficulty with focus. So it's really important to consider brain involvement in any patient with CPEO, even though CPEO is more known as an eye disorder. Hearing loss can happen in any patient carrying any mitochondrial DNA or nuclear gene defects. So hearing loss is very common in mitochondrial disease and should be screened for. Difficulty with swallowing, also very common, and all other organ systems mentioned here. So you see, a holistic approach to assessments of our patients in clinic is very important in all patients, children and adults. This is a table that we found from a paper published in 2015 to show the types of symptoms that patients with a single mitochondrial DNA deletion were presenting with. And you can see from the extent of this table, from top to bottom, how extensive all organ systems were involved. This would be a combination, though, of Kearns-Sayre syndrome patients and not just CPEO, but it's really just to home in on the fact that all organ systems really need to be screened for. If you don't look, you won't find. How do we make this diagnosis of a single mitochondrial DNA deletion syndrome? First, patients come to clinic for an evaluation, and the first line of diagnostic testing nowadays is always genetic testing. I have mentioned here first muscle biopsy because in fact, many of you may have either had it or have had this discussion or have heard of others who have had a muscle biopsy, because it's very common for people with single mitochondrial DNA deletion disorders to in fact have had a muscle biopsy because this is where the single deletion is identified. So what is seen on the muscle biopsy? First, the pathologist will take the muscle tissue and examine it under the microscope. What is seen are these very typical changes that are described, and these are textbook appearances that would highlight concern for a mitochondrial disorder. They are not diagnostic of a mitochondrial disorder because, as mentioned before, what is diagnostic is your genetic test result. However, these clues will shout out to the pathologist, who will then share with the provider who ordered this test that indeed there is concern for a mitochondrial disorder. So these are COX negative fibers, these are ragged blue fibers, and these are the very typical ragged red fibers. This is terminology that you would see in the charts of patients with mitochondrial disorders, not just single mitochondrial DNA deletion, but you may also see it due to other factors such as medications or other inherited disorders. So it is not confirmatory evidence of mitochondrial disease, but certainly a very strong indicator that it has to be considered. The further test that is performed by the pathologist is a higher magnification assessment using electron microscopy, where they can actually now really look down to the ultrastructure of the mitochondria. So where this image right here is looking at the muscle fiber on the whole, now if you use higher magnification, you can actually look at the mitochondria and see what they look like. We understand that the mitochondria shape, size, and volume are in fact not within the normal in patients with mitochondrial disease, but what is typically seen in very typical textbook concern for mitochondrial disorder is raised by the appearance of what is seen here. I'm pointing with my cursor, and this is what's called parking lot inclusions. It's an appearance of the aggregated ragged red fiber mitochondria. This raises concern for mitochondrial disease. Diagnostic testing by way of molecular genetic testing is in fact how we confirm a single large-scale mitochondrial DNA deletion. SLSMD or SLSMD is what you will see in the literature, single large-scale mitochondrial DNA deletion, and if there's an S at the end, that's syndrome. So syndrome would be the clinical appearance, whereas SLSMD, SLSMD itself, is a description of the single large-scale mitochondrial DNA deletion, where parts of the chromosome are deleted and missing. I will state that at CHOP, we conduct what's called a CHOP mitogenome test. So this is a highly sensitive assay to detect the presence of a single large-scale mitochondrial DNA deletion, and it can be performed in blood or muscle tissue. This is crucial. This is crucial for a very important reason. It may be missed in blood, whereby blood cells are constantly turning over. Muscle tissue is not turning over. And therefore, if there is evidence of deletion in muscle, it accumulates and remains in muscle tissue and will not be lost over time, whereas in blood it may be. So therefore, if a patient raises high suspicion by way of their symptoms and the way they're presenting to the physician, then they would have to proceed to having a muscle biopsy if nothing was found on genetic testing by way of whole exome sequencing. If you have a muscle biopsy that has mitochondrial DNA sequencing or CHOP mitogenome performed that does not show a mitochondrial DNA single deletion, then vice versa, it probably wouldn't be identified in blood. So therefore, muscle definitively is the confirmatory test for having this disorder. So I've just shared here the publication that Dr. Wang, the director of the CHOP laboratory that conducts the CHOP mitogenome, that we conduct on any patient now who has a muscle biopsy at CHOP. The CPEO and the single mitochondrial large-scale deletion disorders are sporadic, so it's a genetic disorder because it's due to a defect in the genes. It is not inherited. It is known to be a sporadic disorder because it is not passed down like most of the other mitochondrial disorders. That said, there are rare cases in the literature reporting instances of inheritance. And so we think that at most, the risk for inheritance is at best 4%. In the bulk majority of cases, this is not an inherited disorder. This is a sporadic disorder. Because it's a mitochondrial DNA disorder, there are very important concepts that need to be understood. First, there's a concept of heteroplasmy, and this is where there's mutant and normal mitochondrial DNA, both in your cells, and we express a deletion heteroplasmy level with a number, and the number expresses the mutant level. So the higher the number, the higher the mutant percent versus the wild type or normal percent. The other really important thing about mitochondrial DNA disorder, and this is a really important concept, is tissue specificity. So that's where you need to look in different tissues if first not found. So one would always start in blood because that's non-invasive. But then if not found in blood and still the suspicion is high, we need to move on to muscle. And just share very quickly a case of an individual who presented with symptoms that indeed looked like it was multisystem. There was muscle involvement by way of muscle weakness and exercise intolerance. Then gradually there was the eye signs with bilateral droopy eyelids, ptosis, and limitation of the eye movement, so ophthalmoplegia. And there were other indicators. The stature was short, the growth was slow, and there was GI problems. On the first line testing, which was whole exome sequencing, there was no identified etiology. If one had stopped there, nothing else would have been found. But because a muscle biopsy was obtained, the pathologist confirmed COX-negative fibers on staining and ragged red fibers to, in fact, raise the alarm to the physician to say this might be a mitochondrial disorder. And indeed, when a chopped mitogenome was performed, a single large-scale deletion was found. This was not seen on blood. Hence the importance of tissue specificity, mitochondrial DNA disease. Having a mitochondrial disorder, CPEO, mitochondrial myopathy, it is burdensome, and we have to highlight this to the regulatory bodies like the FDA, to other physicians who are caring for people with mitochondrial disease and may not have seen so many, to families, to industry, to all primary care physicians, eye doctors, neurologists. We have to have the patient voice heard. So it's really important, and we're learning, in fact, that it is important to use the patient voice and report it out in a study and publish it. And having the publication suddenly strengthens the justification for getting drug therapies approved, for getting outcome measures used in clinical trials, and so forth. So we conducted a study of 33 individuals with mitochondrial disease, many of who had muscle problems, for example, patients with CPEO+. Here, we were able to outline the broad, extensive areas of everyday life that are affected by individuals with mitochondrial disease, and not just stopping at the activities of daily life, but also in other organ systems involvement. It doesn't stop at the eyes, it doesn't stop at the muscles, it affects the mood, the cognition, vision, voice, hearing, and everything else. So the importance of showing this to regulatory bodies and to the mitochondrial community at large helps us justify what we need to do in terms of getting approved drug. So how do we manage the situation where individuals are having a broad range of symptoms, ranging from eyes to muscles to GI? Well, first of all, it's really important to even understand which organ systems are involved. So if we see our patients in clinic, we would always then recommend a list of other related specialties to see you, both in children and adults. Regardless of age, it's really important to have an assessment that we call surveillance. If you don't look, you don't find. And remember what I said, involvement of the heart, for example, can be silent. involvement of the endocrine systems may not be so obvious unless you test for it. Therefore, it's really important to have assessments by each of the organ system specialists. And if it is a pediatric patient, for example, at CHOP, most of these can be done in-house. If it is an adult patient, for example, these would be done at an adult facility. And this could be in places that are close to your home. And it's really important to state that the coordination of all these specialists, understandably, can be overwhelming, particularly if your specialists are in different places and in different parts of the state. We understand. However, it is essential to have a cardiology assessment with EKG and echo, a pulmonology assessment with a sleep study periodically to ensure you're not hypoventilating, a GI involvement to make sure you're not having GI dysmotility without being aware of it, an endocrinology assessment to ensure there aren't any endocrinopathies that would in fact be amenable to treatment, screening for hearing, screening for renal involvement by way of labs. So this is the importance of being seen and followed in a mitochondrial clinic. I will state, particularly at CHOP, we have the research interest to quantify these symptoms and to follow change over time, because it's essential to show what the natural history looks like in terms of trying to get drug approved. For example, some of these things can be done on a clinical basis. An EMG and a nerve conduction study or an MRI scan can be performed in order to show what the change over time is. And this may not have to, it doesn't have to be every year, but at least if there's a repeat measurement, one can see how your progression or non-progression, but it needs to be documented for sure. If it's not documented, then you lose that opportunity, particularly in light of potential drug treatment in the near horizon. Let's talk about mitochondrial supplements. This is a reference that I'd like to share. Mitochondrial medicine therapies, rationale, evidence, and guidelines. The first author is Barcelos. If you Google it, you'll be able to look this up. There, we have outlined the types of mitochondrial supplements, the individual components of a mitochondrial supplement, the types of ranges of doses that we use to prescribe, and the reasons for it. In general, this is shown to be safe as long as you don't overdo the doses. So given the favorable risk-benefit ratio, it is standard of care in the US at least to support the empiric use of mitochondrial supplements, which we consider to be mitochondrial treatment. The overarching goal is to stabilize and enhance metabolism, improve your energy levels, maintain your disease stability and/or improvement, and if there is progression, to try and attenuate it. It's generally prescribed in a combination and not just a single. Here at CHOP, we're big supporters of having multiple components of the supplements compounded into one liquid or one capsule. If this is expensive and not covered by your insurance, then the individual supplements can be obtained. The problem in our community, though, is that none of these are FDA approved, none of them are regulated. Hence, there's a very, very big push and big motivation, of course, to seek FDA-approved drugs. More on patient management. Physical therapy, we have Jean Flickinger, who will describe to you in a little while the importance and benefits of exercise. Exercise, we will point out, Jean and I will always state to patients in clinic, it is not the type of exercise that means you go to the gym and have to work out. Movement, any movement and activity around your home is considered exercise, and it's good for your mitochondria. We cannot emphasize enough the importance of good nutritional intake. By good nutritional intake, we mean adequate amounts each of the macronutrients that are necessary. So protein, fat, and carbohydrate. It does not mean just healthy eating of salads and fruit, which may not carry adequate caloric intake. It is important to eat enough. When we studied our patients and looked at their nutritional intake, it was astoundingly new discovery to us to realize that patients, even those who were reporting that they were eating enough, were in fact not eating enough. Patients were eating, on average, only 78% of what they should be. Remember, your only energy source to your body is from food. I mentioned earlier the importance of monitoring and measuring your symptoms over time. If you have CPEO in your eyes and you might likely have CPEO plus in your muscles, it is important for us to assess you and to measure the level of involvement in the different muscles. This is Jean Flickinger, and she conducts these assessments routinely in clinic. Here she's measuring strength and muscle fatigue by way of repeated muscle contractions, balance, which is clearly a big problem across our patient community, your exercise intolerance, and this is a 6-minute walk test, how well the patients are using their hands, and how well you get up off a seat, because all of these activities are important in everyday life. What's really useful is that then we convert all of those measures into z-scores based on comparison to the general population, and then we show the rate of change over time. This work was supported by the UMDF. I started all of this with Jean back in 2017. We've been collecting data for a long time, and now it's covered by the NIH. We continue to follow our patients over time because it's crucial to show what the rate of change is prior to having drug treatment on board. You will see by the blue lines that are being shown in each graph that there is a slight decline, and it is not a horizontal line. However, it's a very, very mild decline. So what we're showing here, for example, in wrist extension is wrist extension strength. So we discovered in our patients that in fact, wrist extension strength is in fact weak across a lot of the patients. What the data shows here is that the muscle strength does change over time, and this is over months, so therefore 60 months is 5 years. And the z-score essentially means comparison to the general population. So anything below -2 z-scores is abnormal, and you see the patients start off at a low score. So wrist extension is indeed wrist extension weakness, I beg your pardon, is indeed prevalent across patients with mitochondrial disease, including patients with CPEO. And however, I will reassure you that the change that we are documenting over time is small. It is a small change over time that it might take 2 to 3 years before some of these changes become apparent to you or become problematic to you. Regardless, there is change over time that we are documenting, and this is helpful indeed because when it comes to having clinical trials of medications, we are now able to say whether the medications are able to slow down this decline. But I will re-emphasize again, Jean and I are showing that with good management of patients in clinic, that in fact, the magnitude of change over time at minus 0.17 of a z-score is very small. So this is good news. Jean measures most muscle groups, does 3 balance tests. She measures the dexterity in your hands because we understand that is a problem in our patients, and we measure muscle fatigue. We put it all together and we show it by way of data like this, and suddenly this type of data helps inform the design of future clinical trials. This is how helpful it is. Another way that we measure our patient's disease is by way of imaging. We have a particular type of research imaging tool here at CHOP called CRSS, where we're able to have the patient lie in the scanner and actually exercise on an exercise pedal. By pushing on the pedal, you are now pushing the need for your mitochondria to start producing energy for muscle contraction. And if the replacement or recovery of muscle creatine, which is your initial energy source within the first couple minutes of exercise, is slow to accumulate, that means your mitochondrial function is generally more inefficient compared to a general person. What we've shown is indeed the measurements are prolonged in a patient with mitochondrial disease here in red compared to healthy controls in blue. Therefore, this is shown to be a very important and useful measure of mitochondrial function in your muscle without having to take a muscle biopsy. Currently, this is only available on a research basis, but we are working hard to finally get this to be able to be a clinical test so that every patient is able to have it. I will now invite Jean Flickinger to join us by turning her camera on to speak to you now about the benefits and evidence for exercise in mitochondrial disease and CPEO. Thank you, Jean.
Hi, thanks for having me. A physical therapist working with Dr. Kipling at CHOP. Hopefully everyone is aware that exercise is really important when you have mitochondrial disease. But what kind of exercise is most beneficial? And that's a tough question. Indeed, endurance-based exercise is the most studied in mitochondrial disease. And by endurance exercise, I mean a submaximal level of exercise, usually a lower load for a longer duration. And that's usually about 30 minutes or more. So there's some evidence to suggest that endurance-based training can improve tolerance to exercise, and that's evidenced by a decreased RPE, which is a rate of perceived exertion. So it's a rating scale used during exercise. It can improve peak VO2, and that is the skeletal muscle's ability to take the oxygen from the blood and allow the skeletal muscles to use that oxygen. And that's really important in mitochondrial disease. And then also there's improved quality of life has been noted in a lot of the studies. And really important here, if the exercise is stopped, usually you'll lose the benefits from exercising. So you need to find an exercise that is going to suit you and it's going to be a lifelong thing, which is the tough thing. A lot of the studies are limited with small sample sizes. I did want to highlight a particular study by Tavasalo et al. In 2006. They studied 8 adults, male and female, with CPEO. They also had symptoms of exercise intolerance, and some of them had symptoms of weakness as well. And they did an endurance-based exercise program, 14 weeks, riding a cycle. If you look at the diagram to the left, for 14 weeks, they rode on the stationary cycle. And I think it was for the initial 7 weeks, they were 3 times a week. And then the next 7 weeks, they bumped it up to 4 times a week. And that's really important too in general. When you're exercising, you can't just do the same program and not change anything. You want to gradually progress that exercise to continue to receive the benefits from the exercise. So after the 14 weeks of exercise, half of the group stopped exercising and the other half continued exercising. And that's where they found that the ones that did not continue the exercise returned back to where they were at the baseline of the study. So that's really important to be consistent with your routine and also progress it and continue to exercise. And that's mainly all I wanted to point out there. The next slide is strengthening exercise is much less studied in mitochondrial disease. We have a study here in mito disease that I'll highlight in a minute, but in general, strengthening or resistive exercise involves a higher workload or intensity for shorter duration and lower repetitions. Now, there's definitely variations on that theme, but most people, when they talk about resistance exercise to gain strength, they're talking about lifting pretty heavy weights and for a shorter duration and lower repetitions. So there's some evidence in the literature that suggests that strength training can improve strength. That's the obvious one. It's well tolerated and safe. And then and this study below highlights this one, exercise-induced mitochondrial gene shifting in muscles containing satellite cells. And these satellite cells, they're like precursor cells in muscle tissue. And these cells have lower or absent levels of deleted mtDNA. So you have less levels of
Mutant, yeah.
Mutant, thank you. That's the word I lost. Yeah, so less levels of mutant DNA in your muscle tissue that could be induced by strength training. Again, very limited studies here. I want to highlight the study by Murphy et al. In 2008. And again, this group, the subjects were 8 females. They were adults. And they had CPEO as well as exercise intolerance, similar to the other group. They focused on leg exercises, 2 different exercises, a leg press and leg extension. And I think they used the machines, the exercise machines for this study. And this led to increased strength, improved muscle oxidative capacity. Again, the improved ability for the muscle tissue to use that oxygen. And this is, again, increased satellite cells. So again, in general for exercise, it's really important that you have a program that's patient specific. So it's specific to your needs. You should be fully evaluated before starting an exercise program. Really work with your physical therapist who can kind of gear that exercise program specific for you. And also there's many other types of exercises out there. We as a whole need to do a lot more studying in our mitochondrial disease patients to see which exercises might be beneficial.
Wonderful. Thank you so much, Jean. And I just want to end off by stating what I'm sure many of you have already heard of. And I will state, as I did mention in the Q&A earlier, that the UMDF have always advertised that they have on their website the names and numbers of active trials currently being conducted in mitochondrial disease, including at CHOP. We are a site for the PRISM trial conducted in Milas right now by Tecento. But we also have a few other studies that are either what's called investigator-initiated, meaning it's started at CHOP, and for example, Dr. Demsko is conducting a trial in Leigh syndrome. But we have other trials here. And the trials that I will state, because it was a question in the Q&A, trials that are targeting patients with mitochondrial myopathy, muscle problems. If you have CPEO and you may have muscle problems, then that would be relevant to you. So although there may not be a trial specifically mentioned that is targeting CPEO patients at this current point in time, the trials that are seeking to enroll patients with muscle problems, such as mitochondrial myopathy, may be relevant to patients with CPEO. Okay, that's really the main point I wanted to make. All right, so the physical therapy program in our clinic, led by Jean Flickinger, is really incredibly productive. At CHOP, we see about 1,700 physician visits a year. We follow over 400 patients with mitochondrial disease who are genetically confirmed, and Jean and her team see about 400 patient visits a year. So we do a lot of assessments, generally of the MM-COAST that we showed the data for, Jean's new measure, which is MM function, which actually measures and quantifies your function over time, and then some other measures that are relevant to younger patients. This is a photo of the team. We're conducting real-time assessments at the UMDF Clinical Research Pavilion. We've been doing that since 2023. Look forward to it this year. And we will be speaking about this. Kara reminded me on the call in March. But now I just wanted to finish off by stating we do have a couple of clinical research studies that are very relevant to patients with CPEO. We are looking for volunteers from the patient community. The first study is seeking the utility of passive exercise. So passive exercise with a special ingredient. Basically, this device produces a tapping, and the tapping essentially mimics jogging. And essentially, this is a mimicker of active exercise. If the effects of the PGZ, which have been published and tested in other patients in the general population, including patients with diabetes and hypertension, and have shown to benefit them systemically in the same way that active exercise has, why wouldn't we test this in mitochondrial disease? So this is what we're doing now. I just wanted to state that we're, first of all, trying to understand that this ability to exercise our patients using a passive jogger would be feasible and tolerable to patients with mitochondrial disease and CPEO, that it would be comparable to active exercise, and it would be reliable in determining your change in your mitochondrial function over time. For this study, we are seeking to recruit anyone over 10 years of age. The study coordinator is Daniel McGinn, who is on this call. This is his email address. Please do reach out if you have any interest in helping us perform the studies, whereby the goal is to try and see if passive exercise would be a good alternative that eventually we would be able to prescribe to patients with mitochondrial disease. We're testing either patients sitting up using a gentle jogger or lying down in a bed that is passively shaking you. Our results so far are very convincing for the fact that these passive exercise modalities are in fact improving the perfusion in our patients in the same way that active exercise does. And remarkably so, the effects of these passive exercise is in fact seen more so in patients with mitochondrial disease here in orange as compared to healthy controls in blue. So this is a very exciting time for us to try and see if in fact we might be able to have some success in finding an alternative for patients who are not able to engage in active exercise. We also have a second very exciting study where we're testing the utility of a nanosensor into skeletal muscle that will be able to tell us in real time what our patient's mitochondrial function is. For this test, we are seeking to enroll adults with mitochondrial disease. Patients with CPEO would be incredible. Again, here is Daniel McGinn's email address, where we're looking to understand if we are able to measure your mitochondrial function in real time by way of a device that is implanted in the same way that a glucose monitor is. And I will end my talk there. Thank you very much for listening.
Thank you, Dr. Karangia, and thank you, Dr. Sokipley Cunningham. We only have a couple of minutes, and I've looked at the remaining Q&A questions. We probably will have to answer some of those post-event, but there were two that I could kind of summarize that I think would be an important thing to include. And I'll be directing to both you, Dr. Cunningham, Sokipley Cunningham, and to you, Dr. Karangia. So for Dr. Karangia, is there a list of neuro-ophthalmologists? How would a patient find a doctor to help them?
So depending on where you are, if you go to the North American Neuro-Ophthalmology Society website, there is a directory on there that you can look up to see where there's a local neuro-ophthalmologist that might be able to assist you.
Thank you. That's a wonderful tip. That's exactly what I was looking for. That information is always really helpful to our patient families, just to know a place where they can start to look. Sort of the same question for you, Dr. Sokipley Cunningham. What does a patient do that lives in a state where they don't have a Mito Care Network Center or any comprehensive Mito Care? What would your first step be?
Yeah, no, we hear this a lot. We understand and we sympathize that is hard. Well, I would say first you can speak to the UMDF, who are incredibly helpful at helping you. Will help you. They can direct you to the closest center to your state. But I will state from our own experience here at CHOP. In fact, most of our patients come from out of state. And they come for that exact reason. They come from states that do not have mitochondrial centers, that do not have physicians with great expertise in mitochondrial disease, but they may have a neurologist who's willing to help, a neurologist who's seen or understands mitochondrial disease, but may not have extensive experience. That's already a big help. There, you would follow the same model we do, and I'm sure Dr. Cohen does the same and Dr. Haas does the same, where you would travel to the mitochondrial center and be seen there perhaps once a year, but in between you would be seen by your other physicians who can help conduct the surveillance assessments and the ongoing systemic assessments and everything else that is needed based on your symptoms. So the village that you accrue is really important.
Well, thank you so very much. It's 8 p.m. and time to wrap up. I want to thank all of our speakers today. This was so informative. And for those of you that had remaining questions in the Q&A, we will work to get those answered for you post-event if we have contact information for you. I do want to let everyone know that next month on Wednesday, February 12th from 7 to 8 p.m. Eastern Time will be our next Ask the Mito Doc webcast series, Comprehensive Care in Kern Sayers and Pearson Syndrome, Diagnosis, Symptom Management, and Support Strategies, with two great speakers, Dr. Rebecca Ganetsky and Dr. Sumit Parikh. So we hope you'll all join us then. You should receive an email or get a notification or see on social media when the recording of this session today is completed, which shouldn't take too long. So again, thank you to our speakers, and